Hi everyone, welcome to this new session of Tuesday Lunch with Rita webinar. So this is every first Tuesday of the month, as you know, and we start a new year now with this new and appealing title on histiocytosis, inflammation, and Rosai-Dorfman disease. So first I'm Alexandre Belot. I'm a pediatric rheumatologist in Lyon, France, and part of the French National Reference Center for Rheumatism, Autoimmunity, and Type 1 encephalopathies in the pediatric hospital in Lyon. And it's my great pleasure to be your moderator today. So please use the chat to ask any question you may have during the different talk, and we will answer the question at the end of the two talk we're going to have today. So we have two speakers, talented speaker and expert in histiocytosis. And we will start with the Professor Julien Haroche, who's a professor specialized in internal medicine at La Pitié-Salpêtrière Hospital in Paris. And we will have a talk on the disease of Detombe Rosai-Dorfman. And Julien, the screen is yours.
Okay, thank you very much. So normally all of the slides are mostly in English, and so it's a bit provocative, but I think Rosai-Dorfman Detombe is more like a syndrome, and it's very polymorph, and it has been first described actually by Detombe, who is a French pathologist who worked in Africa and then in the French West Indies. And he actually, his name is often forgotten by even the French pathologist. So the known cases are probably between 3,000 and 4,000, and there is in this 2018 Blood paper just a prevalence of 1 out of 200,000 with 100 new cases per year. And you can see on the right part of the screen, so this pathologist died in early 2000, and he made his thesis on blénorragie, on I forgot what's the right name in English, but it was infectious disease. And you can see that actually the first publication in 1965 was in this French paper, and it was in between observations on Monterey country and Borrelia infection, and the results of electrophoresis with patients from Gabon, and it was called adenite with lipidic overload in infant or young adults in French West Indies and Mali. And in 1969, Juan Rosai and Ronald Dorfman added 34 new cases of what they call sinus histiocytosis with massive lymphadenopathy. And most of those cases involved Black children, and after that it was also described in Asia. So here you have an example. This was taken from 1965, and you can see that most of the cases are characterized by lymph node enlargement. So sometimes it's like bulky. Most of the time you have high CRP, and the general status is conserved, and you just wait and see. And if you do a biopsy, you will have histiocytic infiltration, and you can see nuclei lymphocytes within the cytoplasm of the histiocyte, and it's a quasi-pathognomonic image, which is called emperipolesis, which is not mandatory, but which is very often seen in Rosai-Dorfman. So some of the images that you can see, about 5 to 10% have CNS involvement, most within the brain. You have also a spine compression, and when it's in the brain, you can have leptomeningeal infiltration, and also some pachymeningitis, which is very frequently seen, but it's not pathognomonic of Rosai-Dorfman. So there is clearly, and it has been described mostly in the past 10 to 15 years, an overlap with IgG4, in particular when you have pulmonary involvement and sclerosing cholangitis, and also eye involvement. And I will not speak about the genetic form, which Maurine is going to speak right after. So as you can see, and that's why it's for me more a syndrome than a disease, you have the Princeps description, which was bilateral painless neck nodes, which is seen in 90% of cases. You can have other nodes that are involved. And the severity of the disease is mostly when you have extranodal infiltration in about 40% of cases. And virtually every location and involvement in the body can be affected by the disease, with orbit, sinuses, kidney, lungs, gut, and rarely CNS. Most of the patients have high CRP. It's higher than what you see, for instance, in Erdheim-Chester disease. And there is often hypergammaglobulinemia and autoimmunity. So you have to look for that with at least anti-nuclear antibody, and also autoimmune with a Coombs disease, and also with a Coombs test, sorry, and also with hepatitis autoantibody. So in this 2002 analysis, you can see that half the patient did not require any treatment. So the first thing is wait and see, as for some of LCH aspect, and you usually treat the patient when you have massive and bulky infiltration that compress other vital organ, because most of the treatment that were given as first line before the MEK inhibitor, it's steroids, 2-CDA. You choose rituximab when you have autoimmunity. There are also some papers with methotrexate, interferon alpha, imatinib, etc. And sometimes you have surgery, which is needed. So this MAP kinase pathway that was described in early 2000 with the BRAF mutation. BRAF is mainly seen, you can see, in LCH, Langerhans cell histiocytosis, and Erdheim-Chester disease, and it is not seen in Rosai-Dorfman disease. So this is one of the main differences between those three histiocytic disorder. And BRAF was the basis of the new classification of histiocytic disorders, which take into account molecular alteration. And you can see that you have LCH and ECD, and Rosai-Dorfman is within the C group, where again you don't have BRAF mutation. In this analysis, so Jean-François Emile, who is who is receiving most of the cases from biopsy samples, you can see here that out of almost 2,000 samples with histiocytic disorders, he identified 212 Rosai-Dorfman disease. And you can see that 133 were analyzed with clinical data, and you can see that there is just pure RDD in almost 80 patients, and an overlap with IgG4. And there is not much difference in the clinical aspect, as you can see here. Don't forget that you have ENT localization, maybe a little bit more CNS in Rosai-Dorfman Sol versus the one with IgG4. And this is an ongoing, we're trying to analyze all the patients that we have. And Fleur Cohen-Aubard did about 10 years ago an analysis out of 47 patients with more men than women. The median age at diagnosis was 20 years, but you can see the range was 1 to 60. Again, about 70% of this series had lymph node enlargement. There was bone, skin, CNS, ENT, and eye. And you can see that, interestingly, there was 3 distinct patterns. About 55% of the patients had the typical RDD, like the form described by Detombe, and 1/3 had Rosae without with extranodal, which were either CNS or bone involvement. And also another figure I will interesting features of overlapping histiocytic with an hematologic malignancy, either ECD or LCH, or also myeloproliferative syndrome and Hodgkin, which were 7 cases. As you can see here, this was a treatment and prognosis of this series, and so they were treated by all the drugs you see on the left. We had 2 deaths and also 1 amyloidosis, and so treatments were not well codified, and this was obviously before the MEK inhibitor. This is a clinical case of a patient I saw more than 20 years ago who had massive lymph nodes, high CRP, IgG kappa, and who had the CD68 plus cells, which is a pan macrophagic marker. 80% of cases are PS100 positive, and they are always CD1A negative, which is a marker of LCH, and the patient had emperipoiesis. And you can see the major lymph nodes and also some major skin involvement that was also seen on the face. So he had all these lines of treatment, and this was in the pre-targeted therapy era. And so he had, and each of those lines of treatment had small efficacy. As you can see here, you have the different line of treatments, and you can see that the CRP value was up and down, but sometimes as high as 180. And over time, creatinine got higher, and he finally died of amyloidosis. So it's not always a benign disease if you do not control inflammation. So this was a consensus recommendations of expert, but I mean, there was no real scoop in this paper, besides the fact that you can see that most of the patients had KRAS mutation and MAP2K1. And you can see here that in more than 2/3 of the patients, you know there is an activation of the MAP kinase pathway, but you don't know where the mutation here. The year after, colleagues from Memorial Sloan Kettering, you see they had only 17 cases of Rosae-Dorfman, and again, KRAS and MAP2K1 that were found. So in 2017, this was the first case of a patient with Rosae-Dorfman disease with major kidney involvement, and you can see that this patient was responded very well to MEK inhibitor cobimetinib. And in 2019, that same year, Eli Diamond published in Nature this letter, who had mostly ECD patient, but also 2 Rosae-Dorfman disease. And this was just pure clinic published as a letter in Nature. And we conducted with Fleur Cohen this PHRC, which was the first randomized placebo-controlled double-blind study. And you can see that during the 3 first months, patients had either placebo or MEK inhibitor, and at the end of the study, every patient received 9 months of cobimetinib, and we included all patients by the end of 2021, and we're expected right now to have the publication of this study. So there is an overlap with different histiocytic disorders, and as you can have LCH and ECD that are BRAF mutated, which is interesting is that there is also some patients with Erdheim-Chester disease with classical ECD who have a tissue biopsy with Rosai-Dorfman. This was a 3-center study, and most of the patients had testis localization, and it was driven by MAP2K1 mutation. Even more complicated, this patient had a typical, at the end of 2008, involvement of pleural disease with Rosai-Dorfman. He had skin involvement with LCH, and then he had a phenotype of Erdheim-Chester disease. He wasn't complaining of anything. And a few years later, he developed myeloproliferative disorder with JAK2 mutation, and then he died of acute myeloid leukemia. So there is probably something in a very immature cell which can give many histiocytic disorder, in particularly Rosai-Dorfman. At the end of the pathway, you have, if phospho-ERK is expressed, and you have a Rosai-Dorfman with severe involvement, like such as CNS, you can give a MEK inhibitor. We did this ECD clustering study with 661 patients. And what is interesting is that, sorry, skip this slide, but we did the clustering analysis, and you can see that half of the patient had the classical ECD involvement, but 10% had the MAP2K1 mutation, which is seen on the right part of your screen, with here on the on this plot, you can see that 10% of the patient had true ECD, but had testis involvement with MAP2K1 mutation. So it's 10% of the ECD patient had overlapped Rosai-Dorfman and MAP2K1 mutation. Some novelty about on the last few years was the expression, and it is used by most pathologists, and Jean-François Emile look at OCT2, which is a marker specific of Rosai-Dorfman, and also activating mutation of CSF1R, which is an important receptor of tyrosine kinase, which is a receptor that is important for the development of macrophages and monocytes. And in 2022, we had more than close to 20 patients with RDD with CSF1R receptors that was expressed. And what is important is that we don't have it in Europe because there is sometimes some liver some not liver failure, but some liver side effects. But in the States, they have access to pexidartinib, which was at least efficacious in a couple of patients with ECD and also in Rosai-Dorfman. So my take-home message, it's the spectrum of the disease remain mostly unknown, very heterogeneous form, sometimes far from the 1965 description without lymph node enlargement. There is an overlap of IgG4 autoimmunity and the genetic form that Maurine will speak just after. In most cases, phospho-ERK expressed, so we know that there is an involvement on the MAP kinase pathway, but we don't know in 2/3 of the patient where the mutation is. BRAF is almost never mutated. The prognosis is unknown. Beware of amyloidosis. We have at least 2 cases who died of such complication. ENT and CNS involvement have worse prognosis. When you have ENT, it's often KRAS mutated. And think of MEK inhibitor. Specificity of amperipilesis is unknown, and they are clearly overt hematologic neoplasm associated, and association with true associated with ECD in 10% of the patient, and also OCT2 and CSF1 error, which seems prevalent in RDD. So thanks for most of the cases that have been referred to us, and the very rich collaboration we have with the colleagues in New York.
Thank you very much, Professor Haroche, for this fantastic overview on Rosette-Hoffmann spectrum disease. And so we will take the question at the end, and we now move to Dr. Maurine Jouret. She's a talented pediatrician working in pediatric rheumatologist and interested in histiocytosis as well. She came from Belgium and went to France in Lyon now, and she will present us a subset of Rosette-Hoffmann disease, which is the H syndrome, possibly under-recognized, and you may have this patient in your own consultation, possibly. So Maurine, the screen is yours.
Thank you. Can you see my screen?
Yes.
Yes, it's okay?
Yes, perfect.
Perfect. So I'm pleased to talk about the H syndrome today, a poorly known genetic histiocytosis that includes very inflammatory manifestations. So this disease is called H syndrome because of many of its manifestations begin with the letter H in English, such as hyperpigmentation, hearing loss, hepatosplenomegaly, hypertrichosis, low height, and heart abnormalities. These symptoms are key characteristics of the disorder, and H syndrome is not typically classified as an autoinflammatory disease, but it belongs to the group of histiocytosis similar to Rosette-Hoffmann disease. We will begin with an introduction focusing on the pathophysiology of the disease to better understand its underlying mechanism. Next, we will discuss the French cohort patients, analyze the clinical findings related to H syndrome, and explore the available treatment options. So, initially, the patients were classified under different syndromes due to the clinical similarities. However, over the years, we observed that these patients share the same genetic backgrounds, all linked to the SSC29H gene. And in 1998, the first family was a form of genetic histiocytosis was reported, and the syndrome was named Fazalabat histiocytosis. Later, other patients were grouped into related entities, such as pigmented hypertrichosis with insulin-dependent diabetes mellitus, or familial Rosette-Hoffmann disease. H syndrome was the first associated with SSC29H gene in 2008, and this gene was also found in patients presenting with dysosteosclerosis. In 2013, the first reports of autoinflammatory manifestation in H syndrome were described. To date, approximately 200 cases have been reported in the literature. The SSC29H gene encodes for the nucleoside transporter ENT3, located in the lysosome of the macrophage. ENT3 plays a pivotal role in the renewal and the maintenance of mesangial and hematopoietic stem cells, and when ENT3 is dysfunctional, nucleosides become trapped in the lysosome, leading to their accumulation, and this nucleoside accumulation activates toll-like receptor 7 and 8, triggering downstream MAP kinase signaling, which induced a pro-inflammatory transcriptional responses and promote the persistent histiocytic lesions. In mouse models with SSC29H3 activation, macrophage accumulation has been observed in spleen, but also in the liver, in the kidneys medulla, and in patchy areas of the pancreas. The phenotype can be restored either through hematopoietic stem cell transplantation or by inactivating the TLR gene. In human models, flow cytometry detected activated monocytes secreting various cytokines. The levels of these cytokines were reduced when we use MEK inhibitors, and tissue biopsies showed strong positivity of phosphor ERK. These findings suggest the involvement of the toll-like receptor 8, MEK, and ERK signaling pathways. These pathways play a key role in innate immune responses and various cellular processes such as proliferation, differentiation, and cell survival. Toll-like receptor 7 and 8 pathways activate various mechanisms that triggers inflammatory responses, leading to cytokine secretion and activation of T cell and B cells. We conducted a retrospective prospective study over a 12-year period to collect various clinical, biological, and radiological findings. A total of 41 patients were identified, and we were able to collect data from 32 of them, all of whom had genetically confirmed H syndrome, and the study includes both children and adult patients. The diagnosis was delayed until adulthood for some patients, and most of them were patients from Maghrebian origin, especially from Algeria and Morocco, which give us some epidemiological clue about the syndrome distribution. As you can see from this slide, H syndrome can affect almost every part of the body. Patients may experience relapsing fever, although most do not. Lymphadenopathies and hepatosplenomegaly are frequently observed, along with skin manifestations such as hyperpigmentation, hypertrichosis, and skin thickening. Joint manifestations were also described, including arthritis, tenosynovitis, and camptodactyly. uveitis and other eye involvement were found. Low limb pain are frequently reported by patients, and sensorineural hearing loss is key manifestation. The most severe complications were due to the macrophage infiltration around various organs, such as the heart or kidneys. Histiocytosis can compress the urinary tract, leading to renal failure, and can lead to pachymeningitis. Heart abnormalities, aortitis, and pericarditis were found in a small number of patients, and this disease is severe with poor quality of life. Unfortunately, 3 patients passed away, including one at the age of 5 months due to macrophage activation syndrome. So this is a complex disorder with broad clinical presentation affecting multiple organ systems. Not all patients exhibit every symptoms, but some can severely affect it, and there is significant variability of how H syndrome presents among individuals. As patients age, the number of lesions tend to increase. Diagnosing the condition in childhood can be particularly challenging, as some children may only show involvement in 1 or 2 organs, leading to potential delays in diagnosis. Most of the symptoms are associated with histiocytic infiltration, although some, such as sensorineural hearing loss, remain not fully understood. When we look at the biological findings in this cohort, elevated inflammatory markers were almost universal, found in 87% of patients. Another significant finding was hypergammaglobulinemia, presented in 55% of cases, and a small number of adult patients presented with monoclonal peak, while others had hypogammaglobulinemia associated with severe respiratory infection requiring IVIG supplementation. One patient experienced local reactivation of BCG vaccine, and we don't have lymphocyte phenotypes for all patients, but in symptomatic individuals, memory B cells deficiency was observed. Autoimmunity was detected in 25% of the cohort, with both specific and unspecific antibodies, such as those associated with diabetes mellitus or anti-SSA antibodies leading to Zika syndrome. Additionally, anti-MPO antibodies were found associated with ANCA vasculitis, and some patients also presented with autoimmune cytopenia. There are specific clinical signs that are highly indicative of H syndrome. These include camptodactyly, which is the permanent bindings of 1 or more fingers, but also skin hyperpigmentation and hypertrichosis. These are important features to look when we diagnosing this syndrome. The histological findings in H syndrome resemble to those in Rosai-Dorfman disease, characterized by an infiltrate rich in histiocytes and lymphocytes, and the presence of amperipoiesis, and it's a process which one cell engulfs another without destroying it. Immunochemical analysis showed the expression of CD68 S100 proteins and CD163, all which are markers for macrophage and histiocytes. And in some cases, the characteristic histological pattern was absent, and only inflammatory cells were observed in the lymph node, leading to the diagnosis of reactive lymphadenopathy. And our French colleague demonstrated that OCT2 expression is consistently positive in H syndrome, regardless of the specific histological findings, make it a valuable marker for diagnosing H syndrome, especially in cases where the typical Roside-Hoffmann disease morphology is absent. On radiological front, we see signs of histiocytic infiltration in various tissues. For example, in the abdominopelvic CT scan, patients often shown a characteristic hairy kidney appearance due to the perirenal infiltration, which is usually observed in Erdős-Csesztem syndrome. And on the chest X-ray, we found hairy heart and pleuropericardial effusion. PET scans are frequently used in the other forms of histiocytosis for the follow-up, and we observe that skin thickening of the inner thing is associated with infiltration of subcutaneous fat, as well as the perisigmoid fat and inguinoscrotal region, and these findings suggest a role of tissue infiltration in infertility with azoospermia observed in some patients. The next image is particularly interesting. The patient presented with a retraction of the hallux and foot pain, and on this MRI, we can see infiltration around the myotendinous region, which may explain both retraction and pain. Dysmorphic clinical signs along the bone abnormalities can be observed, which may lead to the suspicion of constitutional bone disease. And concerning the genetic findings, germline mutation in the SSE29A3 gene are responsible for those autosomal recessive disorder, and this mutation, inherited from both parents, are present in every cell of the body, leading to the systemic manifestation. On the other hand, some mutations refer to genetic changes that occurs after conception and are confined in specific tissues. In patients with H syndrome, somatic gene mutations in the MAP kinase pathway, like MAP kinase, like MAP2K1, have been identified in lymph nodes, as we can see in other histiocytosis. And this observation suggests that histiocytosis in H syndrome may have multifactorial origin, particularly in cases of Roside-Hoffmann disease phenotypes. The dual involvement of germline and somatic mutations points to possible interaction between systemic genetic defects and localized somatic changes that exacerbate the disease. When it comes to treatment, tocilizumab, an IL-6 antagonist, has been widely used in our French cohort, showing effectiveness in reducing inflammatory manifestation like fever or arthritis. And however, for case involving organ infiltration, MEK inhibitors like cobimetinib have shown promising results, particularly in reducing the proliferative lesions. MEK inhibitors are typically used in Roside-Hoffmann disease, and while these treatments are not curative, they may help to manage disease most severe symptoms and improve quality of life. Oral form of cobimetinib is practical, but requires good patient adherence. And I think finding an effective treatment is crucial due to the severe comorbidities observed, including nephrectomy, arrhythmias, spinal cord compression, renal failure or infertility. And hematopoietic stem cell transplantation could be a future option for younger patients, considering the long-term progression of the disease. Here are all the diagnoses previously considered before the genetic analysis confirmed H syndrome. So the differential diagnosis is quite broad, but some clues can help, such the consanguinity or the symptomatic siblings, or an unusual association like NK vasculitis and Rosai-Dorfman disease, or juvenile arthritis and diabetes mellitus. And monogenic autoinflammatory disease were frequently suspected, and the diagnosis was confirmed through exome or whole genome sequencing. So the research agenda for next years is huge because we not completely understand H syndrome, and non-responded questions are numerous. But biobanking of our French patients is on progress, and next step should be to gather clinical and biological data through an international registry. So in summary, clinicians should consider specific clinical signs and conduct genetic testing when appropriate, and collaboration across centers and networks like ERN-RITA is essential to improving patient care. And treatments such as MEK inhibitors or IL-6 antagonists have shown promising results. But we need more research to fully understand the disease and develop better therapies. Collaboration is key improving the management of patients. So I'm available if you have any question, and thank you for your attention.
Thank you, Maurine, for this very good talk on this H syndrome, which is still a mysterious disease and part of the Rosai-Dorfman spectrum. So we are now open for question. You can enter directly in the chat or in the question Q&A. And I may start with the first question for you, Professor Haroche. Why Rosai-Dorfman start early in life? It seems to be more frequent in pediatric context, if I'm correct. And is there any reason for this?
I think you're. I think it starts less. It has less classical pediatric or infant like pediatric presentations than LCH. But if you take the three most frequent histiocytic disorders, LCH is before, then I would say more adolescent patients, you have Rosai-Dorfman, but you have Rosai-Dorfman at all ages. In the SNFME presentation of 2015, out of 47 cases, the age range was between 1 and 60. So I don't know exactly. I think ECD is more like 50 or 60 in median, and I think Rosai-Dorfman is more like 20 years old. If you take the median of this 50 patient series, I don't have the clear the median age of the 133 patient of 2022, but I think it's really interesting to complete the clinical data analysis and spectrum of the whole cohort, especially to know if what is the exact differences between those that have IgG4 overlap with the one that are just pure Rosai.
So in pediatric, we often think that if it starts early in life, maybe there's something associated to germline mutation like H syndrome, for example. And I was wondering if you have in your cohort some patients with the Noonan syndrome, mutation in NRAS, KRAS, or if it was not detected or is not associated.
I think we have one patient who has a Noonan with, I think, NRAS mutation, but so it's very rare to my knowledge.
So Julien, you mentioned the wait-and-see strategy when there is this lymph node enlargement. And
Yeah.
what's the proportion, to your experience, who may transform into malignancy? Is that frequent? Is that not so frequent? There is no risk to wait and see in that situation.
I would say that if it's just like lymph nodes, as you can see on the first or second slide, with no compression of the trachea, the tracheal or the vessels, then you can wait, and the only scar that will remain is those lymph nodes which will become at one point smaller, and the CRP. I think the marker that's important is a CRP, and if CRP is okay and general status is okay, you can wait. When you have the same lymph nodes, which was the case in one of the patient I showed you, the skin involvement, and it was compressing the colon and other gut parts, then you have to give treatment. And I think that considering all the side effects of immunosuppressive drugs that don't really work, I mean, you can first I would start with steroids because it works. Add either methotrexate or azathioprine, and consider MEK inhibitor after if it resists, or a frontline if you have a major CNS involvement, because MEK inhibitor have other side effects which and you cannot use them if you have cardiac dysfunction, for instance.
And so still another question now on the pathology. So you mentioned these new markers such as OX2. I think Maurine, you mentioned this as well, and the phospho-ERK in the slide. So is that something you are doing in routine to check that this is activated and it's a bona fide Rosai-Dorfman, or is it still a part of the research?
I think it should be done. It's the immunostaining phospho-ERK is something that should be done, I would say, routinely when you have facing histiocytosis. You should ask CD68 and CD163, which is another pan macrophagic marker. Check that the CD1A is negative, and phospho-ERK immunostaining, because it allows you, if you have a severe form of the disease, even if you don't know where the mutation is, to start a MEK inhibitor if you have no contraindication, and then you will think afterwards if you can perhaps find a mutation on the pathway. But phospho-ERK is not very complicated, and you have always a doubt if when Professor Emile says that there is that it's not really clear cut if it's positive. Usually he says there is a major I try to remember how he there is a strong expression of phospho-ERK among the histiocytic cells. Sometimes the problem is that there are a few histiocytes, which is more the case, for instance, in Erdheim-Chester disease, and usually there are more histiocytic cells in Rosai-Dorfman than in ECD.
Okay. So Maurine, if we come back to the epidemiology, so for H syndrome, the age is younger than any Rosai-Dorfman syndrome at onset, because in terms of diagnosis, you mentioned that it can be done even in adults. So what's the proportion of diagnosis made in adulthood?
Approximately a third of the cohort was diagnosed at the adulthood, but the diagnosis was frequently evoked on clinical signs, because a patient has hearing loss, diabetes mellitus, and the genetic confirmation was performed later. So I think it was because the genetic assessment is not performed systematically in adult cohorts, and we have delayed diagnosis because of that.
And do you think both, Julien, Maurine, that in front of a Rosé-Dorfman diagnosis, germline mutation in some genes, including maybe RAS and KRAS and SLC29A3 for the H syndrome, and possibly others, should be included in the future to check if there is a specific host condition that promotes the disease?
For me, I think, yes.
Go ahead.
For me, I think it's important to think about all the genes you mentioned, particularly if there is autoimmunity, because as we can see in H syndrome, the toll-like receptor 7 and 8 are implicated in the pathophysiology, and we know that they are associated with autoimmune disease like lupus. So I think it's important to perform a genetic analysis if it's not clearly identified as a lymph node involvement in Rosé-Dorfman disease and various other systemic manifestation.
And for I would say Rosé-Dorfman with typical signs at an adult age with either NRAS or KRAS mutation, I don't think it's important to do like pangenomic analysis or look for germline mutation. If you have, I think it's more interesting in the genetic forms than into
early onset. It's the best way to select maybe this patient. If it's not early in life with a lot of autoimmunity, as mentioned, possibly it's the best way. So there is, the mass is the cause of death in one patient with H syndrome. So macrophage activation syndrome, so suspected to be associated to high interferon gamma production. Is there some evidence that in Rosé-Dorfman or in H syndrome, there is an overactivation of interferons, and in that case, is the interferon signature an interesting marker of the one or the two disease?
I haven't looked over the interferon signature in, I think, in the patients. So I cannot comment on this.
Mm-hmm.
In H syndrome, we perform interferon signature for 5 patients, and most of them have negative results or only a slightly positive interferon signature. So maybe it can reflect interferon gamma secretion. And there is a few case reports in literature with a patient with positive interferon signature who were treated with JAK inhibitors for the joint manifestation with some effectiveness. So I think it's important to explore the interferon pathways, and my impression is that the disease can be related to interferon gamma, but probably not interferon alpha. But we need to perform more exploration on this point.
Yeah, and considering there is this TLS7 and 8 activation, so still a possibility that type 1 interferon is produced, but I agree it looks like more something related to interferon gamma. And JAK inhibitors are also targeting IL-6, so possibly they can improve and the JAK because of the IL-6 inhibition and not that much about the interferon gamma, but it's hard to to say the specific effect in that case. And maybe the last question for both of you: is there any specific viral trigger that should be screened or checked, as for Castleman disease or any other inflammatory disease? We know that they are on this link. Have you seen some specificity with the viral triggers that should be recognized or targeted by therapies in case it's positive, or it's not specifically associated any flares with any viral triggers?
For the adult, for the classical non-genetic forms, I think there are a few cases with cytomegalovirus or herpes virus, but I think it's really anecdotic, and maybe it's part of the I think in the 2018 consensus paper, which is I mean, it's just a recommendation. I think we have put some viral serologies, but I don't think it's a major issue with this. But even if, as you can see, the population affected comes from a lot of countries of Africa, Asia, and so there is maybe or probably an infectious trigger at some point, but not known to the best of my knowledge.
Mm.
It's the same for me. I don't have any association with virus replications.
Okay. So I think we have now reached the end of the webinar, and on behalf of ERN-RITA, we would like to say a warm thank to both of you, Julien Haroche, Maurine Jouret. Thank you very much for this excellent session and for the discussion. Thanks again to those who attend this meeting, which was really exciting and fascinating. So before we go, please note that the next Tuesday lunch will take place next month. And please, you can share your feedback on the webinar by answering the survey just at the end of the webinar right now. And I hope to see you next month. And thank you again, Julien, Maurine.
Thank you. Bye-bye.
Bye-bye. Thank you.